Welcome to QD Clinic. This QD Clinic is devoted to the rheumatoid arthritis questions from the audience from RheumNow Live 2023, held in Dallas on March 18 and 19, just a few months ago. So one of the things we aim to do with RheumNow Live is answer all your questions. We don't get to all the questions during the extensive Q&A sessions that we have, but the leftover ones we're going to cover here in QD Clinic. So these are audience questions and answers on the topic of rheumatoid arthritis. The first pod or session on rheumatoid arthritis featured Dr. Kevin Deane on Preclinical RA, Dr. Stanley Cohen on all things JAK inhibitors, and Dr. Michael Brenner on Fibroblasts, the stromal cells that hold exciting promise for the treatment of RA in the future. So let's get into the questions. We'll go sort of by block: preclinical RA, JAKs, then fibroblasts, then some RA questions. First question from Rachel Tate: are there biomarkers to check for in early RA? Actually, Renuka Bazavaraju asked the same thing. What about 1433 as a marker? Well, CCP is the main biomarker, if you will, of importance in preclinical RA, meaning patients who don't meet criteria, who don't yet have synovitis. What should you be doing? You should be doing CCP and actually RF, because there are some situations where RF may be more predictive than CCP. But in general, the most predictive variable for the development of future RA is CCP. All the other tests that have been studied don't add much more to the equation and probably shouldn't be done. By that I mean mainly the 1433 eta and also the CARB-P antibodies and the other subtype antibodies within CCP, like Vimentin antibodies and SA antibodies, etc. Other tests that are often done diagnostically in RA, including Vectra, have no value in preclinical RA. At least they've never been tested to that end. Again, the biomarker would be something that has true predictive value. If you're CCP positive and have preclinical RA, the likelihood you'll go on to develop RA is somewhere between 20 and 60%. And Dr. Deane said 30% is a good round number, which means you need to follow people. Gerald Zakarn, asked a question: does it make any difference whether you're looking for IgA or IgG ACPA in preclinical RA? And no, it doesn't. There are studies that look at all the isotypes of ACPA showing that there's some additive value. But since those are not generally available, IgA antibodies, unless you wanted to spend a lot more money for a little bit more information, it's not necessary. Another question is there other conditions besides weight or smoking that elevate CCP levels that may account for future development of RA? I think if you have CCP and it's going to matter as far as developing RA, it's de novo CCP or CCP induced by smoking and genetics. I'm not sure that obesity drives CCP autoantibody positivity. As you know, it's generally not positive in any other conditions. But in chronic lung disease, CCP is often positive, and that may not be related to RA. But on the other hand, it's possible that chronic lung inflammation or initially lung inflammation may be the genesis of CCP that may ultimately drive future risk of RA. So to answer the question, I would say chronic lung disease might also give rise to CCP. Jasleen Kaur says asthma is a chronic condition that may be associated with inflammation. Isn't it considered as a precursor of RA? Not generally. However, there is data that talks to COPD, another reactive inflammatory airway disease, is known to be associated with the future development of RA, and RA is known to influence the risk of COPD. Asthma, therefore, could be one of those early inflammatory lung events that could lead to future CCP, could lead to future early RA. Ciara Branch asks, is Vectra DA testing more helpful in measuring disease activity in RA? And the answer is no. It's never been proven to be more effective than measuring sed rate CRP and CCP, and doing a joint exam. As you know, Vector has 14 biomarkers combined into one that's said to have predictive value, yet it's never truly been tested as a biomarker. Nonetheless, it's popular with about 13-14% of rheumatologists by my surveys. I've never used it, find no need to use it. Santhi Penmesta says, what is the data on injury and trauma in triggering joint activity in RA? She's seen some cases. There are some cases like that, and there is some literature about, yes, trauma or stressful events leading to the onset of inflammatory arthritis. It's really strong data, and we covered this 3 years ago at Room Now Live with Dr. Georg Schett, who talked about trauma and manual labor as precursors to psoriatic arthritis. Very well-known association there. Not so well-known in RA, and think back, honestly, of all the early RA, new RAs that you've seen, how many have a history of trauma? There's a few, but not enough that it should be a counseling event, I think, in trying to avoid arthritis. So think about it. Someone has preclinical RA, they have arthralgias, they have CCP positivity, they may have a marginally elevated CRP. Do you counsel them not to do traumatic or manual labor jobs? I don't think I would, based on the data. David Vega Morales says, are there other conditions besides weight or smoke? We already talked about that. Vijaya Murthy, in your practice, what do you personally do in a patient who comes in with polyarthralgia, has a positive RF or CCP without obvious synovitis? I treat the symptoms, meaning if they have arthralgias, I treat the arthralgias. No, I don't use hydroxychloroquine based on Dr. Deane's lecture, which showed the results of the STOP RA trial showing hydroxychloroquine has no preventative value. I would treat with nonsteroidals and analgesics and lifestyle modification. That's sort of the treatment. There's a growing body of evidence that may favor some therapies, and at this point it only looks like abatacept is leading the way with some potential for rituximab or methotrexate, but we need more study. So I'm only managing symptoms. I don't treat synovitis with DMARDs until they get synovitis. And it needs to be chronic in one joint or two or more joints for me to start on a DMARD, and then you would use your usual RA DMARDs. Questions regarding JAK inhibitors. Craig Sokoluk says, do you think the side effect profile of JAK inhibitors would be different if the study looked at patients who are not currently taking methotrexate? And those analyses have been done, and honestly, they're not much different, with the exception of LFT elevations. LFT elevations are probably a little bit higher in those are taking JAKs plus methotrexate. But otherwise, the other risks that you worry about, including zoster or hyperlipidemia or nonsense infections, they're really no different if they're on methotrexate or not. Kristen Holscher asks if you need to use methotrexate. If you need to use a JAK inhibitor, patient with cancer, is there a certain time frame you should wait before starting the JAK inhibitor? So first off, the patient who has a history of cancer and it's a solid tumor, I'll use any drug I want. FDA and not FDA, ACR guidelines say if a patient has a solid tumor, that includes skin cancer, that would include pancreatic cancer, that would include prostate cancer, breast cancer, etc., colon cancer, lung cancer, solid tumor, you treat the patient as if they didn't have the solid cancer. So don't let cancer get in the way of your thinking. That also applies to people who have a prior history of a solid cancer, right? Let's say they have a lymphoma, and now we're going to ask the question, if the patient has lymphoma and gets treated, how long would I wait? I don't wait at all. Meaning, treat the lymphoma. They may go on some regimen that may or not involve rituximab. But again, I don't wait any time frame because I don't believe JAK inhibitors are capable of causing cancer such that I would not use it. You're going to ask me about the oral surveillance study. Didn't that give us a warning that said there was a risk of cancer, especially lung, lymphoma, and skin cancers in patients who took JAK inhibitors? And the answer is that's what the study said, but the interpretation of that could be, one, that JAK inhibitors were not as good as TNF inhibitors in lowering cancer risk, or two, what you're seeing with JAK inhibitors is really the RA risk, because those tumors, lung, lymphoma, and skin, are the malignancies associated with RA and inflammation. So I don't wait. Most of you get really hung up with worrying about how it's going to look on paper if you treat the patient aggressively. Let the oncologist treat the cancer. You treat the arthritis. Violetta Badur asks, would you use a JAK inhibitor in a patient with a venous thromboembolism? And then something about a clinical trial. So if a patient has a history of venous thromboembolism, pulmonary emboli, DVTs, recurrent events, don't use a JAK inhibitor first. You've got many other options. All right. If a patient is on a JAK inhibitor and now all this information comes out about VTE, should you stop? I think you have to have a conversation with the patient. I think if the patient had life-threatening VTEs previously and you have the patient and they're doing well on a JAK inhibitor, I would consider stopping the JAK and trying to find alternative therapy. A patient who has a history of VTE would not go in a JAK inhibitor clinical trial. They would be prevented from being in such a trial. Okay. Kimberly Winsich asks, as far as a 32-year-old female who's on JAK inhibitors, do you have concerns about her getting pregnant? I have concerns about all my young women who have inflammatory arthritis and the therapies I use. I always have to have conversations with them about what is their pregnancy plan and stress upon them that we should, A, have the disease, no matter what it is, RA, lupus, under absolute best control before we try to conceive. Second, I let my patient, get pregnant on almost any drug. I only sort of push patients to take certolizumab, Cimzia, if they want to get pregnant, if it looks like they've got really active disease, and I know for sure I'm going to continue the biologic or therapy throughout the pregnancy. There, I think that Cimzia clearly has an absolute advantage. But most of us are going to let the patient get pregnant on existing therapy, and when they find out they're pregnant, they're going to stop. What's the data on JAK inhibitors in pregnancy? There is some. None of it is damning. It's usually the same kind of no clear signal for fetal malformations. But I don't think we have a lot of data about JAK inhibitors in pregnancy, so it wouldn't be my favorite. We have tons of data about patients getting pregnant on TNF inhibitors. We have more about patients getting pregnant on rituximab and IL-6 and abatacept than we do with JAKs. But the bottom line is you control inflammation, let them get pregnant, and hope that they stay in remission. But you got to watch them and then not be afraid to treat them during pregnancy, even with all the drugs that you're using prior to pregnancy. Okay. Yamini Menon asks, is there a threshold of the CPK with a JAK inhibitor that needs to be withheld if the JAK inhibitor is working for RA, but now has myalgias? The patient also has fibromyalgia. Well, fibromyalgia, myalgia, boom, you've answered that question. The story on CPK elevation with the JAK inhibitors is it happens in single-digit percentages in cohort studies. It never has been associated to, and I've asked all the companies and all the researchers who do the trials, that everyone's seen it, including 2, 3, even 4-fold elevations of CPKs, and they bounce around. They're quite dynamic. They don't sort of rise and continue to rise. They sort of go up and down, but has never been associated with frank myositis or myopathy, such that a muscle biopsy or treatment of myositis and cessation of JAK inhibitors is ever needed. So I like to do one CK elevation in a patient who's on a JAK inhibitor, usually 3 months after they've been on a JAK inhibitor. And unless it's very, very high, I'm never going to do it again. That's how I handle that. David Vega Morales says, is it correct to consider that the safety issues with JAK inhibitors is a class effect? I think the answer is yes. And I think the FDA and the EMA and other regulatory agencies in Canada and UK have all agreed that because all this damning data was seen in the oral surveillance study with tofacitinib, they're going to extend those warnings to the other JAK inhibitors. If you look across the board at all the JAK inhibitors, the profile of safety is pretty much the same. I can't look at one of those drugs from many different companies and say, oh, this JAK inhibitor is clearly safer than that JAK inhibitor. That's not the case. So yeah, I believe that pretty much the safety profile is a class effect. Christopher Koenig says, a 50-year-old with problematic herpes zoster infections on a JAK inhibitor, how would you adjust the problem? Similar to the question from Vishali Dalvi, who asked, do you recommend shingles vaccination in a 40-year-old starting a JAK inhibitor? In my clinic, if you're going on a JAK inhibitor, yeah, I'm going to strongly recommend, almost demand that you get vaccination with the H. zoster vaccine subunit, which is not a live virus. That is, it's an inactive vaccination, so that you can give it hopefully before you start on a JAK inhibitor, but you can give it after the JAK inhibitor. As you know, it's 2 injections. In the United States, it costs about $135 for both injections. About up to 30% of patients are going to have constitutional and minor side effects associated with it, like all vaccinations. But it is like 95% effective, almost regardless of your age. So the problem with doing it under age 50 or under age 40 is who's going to pay for it. And are you going to need to repeat it in the future? I wouldn't worry about that latter question off the bat. I'd probably want to protect them, because if you go on a JAK inhibitor, depending on the other risk factors you have a 4 to 10-fold higher risk of getting shingles in the future. It's so common to not vaccinate, I think, would be a big mistake. Getting it paid for might be the only challenge I have. I have no other safety concerns about giving this to very young people or people not RA, but other conditions that are taking JAK inhibitors. Someone asked, have I ever seen a cough develop with a JAK inhibitor like that you get with an ACE inhibitor that resolves with cessation? Never seen it, looked it up, haven't found anything about it. You've got a rare bird there. Another question from Gerald Zakim. Sorry, Gerald. Is there a method to detect fibroblasts predominating in synovial biopsies without doing a biopsy? This was discussed by Michael Brenner, a truly interesting lecture about what we're not treating. With all our great treatments for RA, we're not treating what's happening with those stromal cells, that they can continue to persist, grow, generate cytokines, and cause damage, even though you've controlled inflammation with either an IL-6 or a TNF or an IL-1 inhibitor or a JAK inhibitor, that we're not really addressing what's going on. And no, there is no way of determining fibroblast predominance from a serologic test or an imaging test at this point in time. More research is needed there. There are three more questions just related to RA. Michelle Costa Cataldo asks, could you comment on vagus nerve targeted therapy and heart rate variability? I'm not going to comment on heart rate variability. That's sort of an autonomic issue as relates to the pathogenesis of RA. It's, I think, still controversial. Vagus nerve stimulation as a means of therapy is progressing. It's gotten into phase 2 trials. It looks good. By doing intermittent stimulation of the vagus nerve, you're basically inhibiting TNF, and that downregulates disease. It's very protean in research at this point. Will it make it to become a real therapy? Who knows? Susan Giles says, we've all seen bulky proliferative synovitis of the wrists and MCPs in patients who are seropositive, but yet they don't respond to TNF inhibitors. Is there anything about the RA phenotype that would predict a better response to an IL-6 inhibitor, a JAK inhibitor, or rituximab in TNF failures? And should we consider synovial biopsy? I wouldn't consider synovial biopsy unless it was one joint unless I had failed everything and they really did continue to have synovitis, or unless I had failed 4 targeted therapies. That's kind of how I've done it. Hence, I've seldom ever done a diagnostic synovial biopsy looking for malignancy or amyloidosis or calcium pyrophosphate deposition disease. Susan, you're asking the question of basically precision medicine and using phenotypic data and profiling. I can give you a few hints. Number 1, seropositivity gives you an advantage in choosing A, rituximab, B, abatacept, and C, maybe a JAK inhibitor. You said your patient is strongly positive for both RF and CCP. I would consider those drugs before I would consider a TNF inhibitor or an IL-6 inhibitor. And I would consider them actually in the order of abatacept first, rituximab second, and a JAK inhibitor third. For IL-6 inhibitors, there was this research from 2 years ago from Sanofi regarding sarilumab showing the rule. Patients were more likely to respond to IL-6 inhibitors if they had 2 things. And this is based on machine learning analysis of 42 variables, 1,000 patients in 4 different studies, or over 1,000 patients, and they came up with the rule. And the rule is a CRP greater than 12.3 milligrams per liter plus CCP positivity made you rule positive and more likely to respond to an IL-6 inhibitor. Brilliant. Easy to employ. Now, that was an abstract presented at EULAR and ACR. It hasn't appeared in print yet. So, but I like the idea of using data to come up with profiles as you're looking for that can help you make decisions on your next best therapy. Last question was, I thought going to parenteral or splitting the oral dose of methotrexate showed greater tolerance for methotrexate. Vijaya, sorry, that's actually wrong. But that's what's implied by the ACR guideline that says if you're having methotrexate toxicity, go to parenteral or split dose oral. That's like the dumbest, craziest, stupidest thing I've ever heard. Because if you go parenteral, you're giving more methotrexate. You're going to get more side effects. If you go to split dose oral, meaning at 15 milligrams, you have variable and low absorption of methotrexate orally. But instead, if you split it up into 7.5 given, twice a day in the same day, you get almost 90% absorption. It's like giving parenteral. Again, you're getting more methotrexate. So if you go split dose oral or parenteral, you get more side effects, not less side effects. And if the patient tells you they have less side effects, congratulations, you just elicited a great placebo response. Tune in next week for more questions from Room Now Live and more answers. We're going to feature questions on psoriatic arthritis next week. Take care.